Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the images that you will see, are based in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present in this channel. In here, you can see the QR code to access the Echo by Web site, for example, for your cell phone right away. The topic of these series of talks, which span over 6 videos, is the echocardiographic analysis of left ventricular diastolic function and dysfunction as seen in the real world. It is a fast, synthetic, basic approach to this topic, which is quite large, and I will provide further on more detailed, a large video with a more in-depth approach. Now, these talks assume that you have a basic understanding on how to perform pulse Doppler and continuous wave Doppler interrogation of intracardiac flow, and also how to use tissue Doppler, myocardial tissue Doppler. And it is also assumed that you know how to perform basic echocardiographic measurements. However, you will find in the website echobyweb.com, I've just mentioned it, a large quantity of material, educational materials to address these topics. This is an outline of the 6 talks on the analysis, the echocardiographic analysis of left ventricular diastolic function and dysfunction. So the first talk we will look at definitions of diastolic function, diastology, and its clinical utility, the utility of the echocardiographic analysis, and then there will be a basic presentation of the physiopathology of left ventricular diastolic function. In the second video, we will look at how to estimate left ventricular filling pressures with echocardiography, and we will look at the current recommendations, the 2016 and 2025 latest recommendations on the analysis, the echocardiographic analysis of LV diastolic function. The third video, we will see a complementary analysis which is based on the assessment with echocardiography of pulmonary diastolic pressure, and then we will see how to estimate LV relaxation and compliance with echocardiography. The fourth video will all be about how to grade with echocardiography diastolic dysfunctions. The fifth video will be on how to report with echocardiography diastolic function and dysfunction, and we will see a series of clinical cases. In the sixth video, we will address the problem of sinus tachycardia and how to solve it, so to perform the analysis also with a fast heart rate. Then we will look on how and why to perform the Valsalva Maneuver. We will look at specific patient populations and see the conclusions. This is video number 3 from the echocardiographic measurement of pulmonary diastolic pressure to the estimation of left ventricular compliance. Although the limitations remain the same as in the 2016 algorithm, so extensive mitral annular calcification, mitral regurgitation, mitral stenosis, atrial fibrillation, LVAD, assisting device, or pulmonary hypertension and pericardial constriction all tend to make unreliable this algorithm. So, complementary to all of this, to really simplify this point and make analysis of diastolic function and filling pressures more manageable, I present you this algorithm which we published a few years ago. You find the QR code to access the PDF publication here on the left. This method is based, as I told you before, on the assessment of the direct assessment with continuous wave Doppler of pulmonary diastolic pressure by measuring the end diastolic velocity of pulmonary valve, the physiologic regurgitation of pulmonary valve. Through the simplified Bernoulli equation, the echo machine calculates automatically the gradient between the pulmonary artery in diastole and the right ventricle in diastole. To this gradient, you have to add the right ventricular diastolic pressure, which is, when the tricuspid valve is open, is right atrial pressure, and you estimate right atrial pressure through collapsibility during inspiration of the inferior vena cava. And what you obtain very quickly is pulmonary diastolic pressure. So the complete methodology of how to do this will be available in another video, which will the topic of which will be the estimation and measurements of the right of pulmonary pressures and the right heart pressures. So why measure pulmonary diastolic pressure? Because, as you can see in this graph here on the left, echocardiography derived pulmonary diastolic pressure here on the horizontal axis correlates very well with pulmonary capillary pressure measured with a catheter in the pulmonary circulation, which is our gold standard. And on this Cartesian graph, correlating the two variables, you see four areas. The area labeled 1 are the patients with normal invasively measured wedge pressure and normal pulmonary diastolic pressure as measured with continuous wave of pulmonary regurgitation. The area labeled 2 are the patients where both methods give increased pressures above 12 in this case, or 15 if you want. The area labeled 4, in this area here, these patients, which are few, echocardiography overestimates true wedge pressure. So for example, this patient here will be 15 to 16, but in fact he has 12 wedge pressure. Now these are the patients with increased pulmonary vascular resistances, moderate to severely increased. In these patients you cannot use this method. Fortunately, there are not many of them around there in your labs. In the area labeled 3, Doppler echocardiography underestimates true wedge pressure, and this is why there is an algorithm. So in patients with increased wedge pressure, the continuous wave Doppler of pulmonary regurgitation is quite accurate in diagnosing increasing filling pressures, and so the algorithm here says that if you measure more than 12 pulmonary diastolic pressure, then you can quickly go without measuring anything else, which I don't recommend because you have to do the whole echocardiographic examination. But anyway, you have straight ahead an estimation of increased wedge pressure. But if your pulmonary diastolic pressure with continuous wave Doppler is less than 12, then it's better to go through the measurement of these parameters, which are the same from the 2016 recommendations. So tricuspid regurgitation velocity, here the cutoff is a little bit less, 2.5. The E/A ratio of the mitral flow, the cutoff is 2, and the biplane indexed left atrial volume, here the cutoff is 37. And again, if you have 2 more negative or 1 negative and 1 positive, you have normal filling pressures. If you have more than 2 positive, you have increased filling pressures. Now, there are 2 clear advantages for this algorithm. There is no indeterminate category. Either you have increased or you have normal filling pressures. And 2, we can estimate increased filling pressures in every patient even if he has mitral stenosis, any kind of gradient through the mitral valve, or frequent arrhythmias or pacemakers. So that is really not a problem, even severe annular calcifications or mitral valvuloplasty. Let's see a couple of examples of measurements. So you, as I said, you begin, this is the pulmonary regurgitation continuous wave Doppler. You start by measuring the end diastolic velocity, then the Bernoulli equation transforms the velocity, calculates the gradient. So this is a patient with a normal pressures. The gradient between the pulmonary artery and the right ventricle is 3 millimeters of mercury. Here, a higher velocity, the gradient is 13. At this point, to obtain pulmonary diastolic pressure, and you have a gradient, so to have pulmonary diastolic pressure, you have to calculate right ventricular and diastolic pressure. So right ventricular and diastolic pressure, you get it by the collapsibility of the inferior vena cava, which gives you right atrial pressure. And by summing the two, so by adding the right atrial pressure to the gradient here, you obtain pulmonary diastolic pressure. So in this normal patient here, you will have 3 as a gradient, normal right atrial pressure, 6 plus 3 will give you 9, so normal wedge pressure. This patient here, which has 13 as a gradient, even if he has normal right atrial pressure of 6, he will have 19. And from that point on, he will always have increased filling pressures. So we have seen the algorithm that allow us to estimate left ventricular filling pressures. But the aim of our evaluation of diastolic function is also to identify the grade of diastolic dysfunction and to identify the abnormalities of the two main determinants of diastolic dysfunction with echocardiography. That is, we have to identify LV relaxation and compliance. Let's start with the evaluation of left ventricular relaxation on this slide, which shows two examples of two different prolongation of left ventricular relaxation. In B, we have a mild increase, and in C, we have a severe increase in prolongation of LV relaxation. This is because we not only have to decide if relaxation is normal or prolonged, it is desirable also to identify if the relaxation is mildly increased or severely increased. That is to say, we also need to evaluate the extent of the abnormality. From top to bottom here, we have pulse Doppler of transmitral flow profile, and we have the tissue Doppler profile from the septal and the lateral annulus. In a normal patient, for reference, in the patients with mildly increased and severely prolonged relaxation. As rapid LV relaxation slows down with the progression of myocardial disease, because it's a progression, the rate at which early flow, the E wave, decelerates, decreases, and therefore the deceleration time increases. So compared to the normal value here in panel A, a normal value of 225 milliseconds with this normal physiology, deceleration time will be this one. In B, the deceleration time increases to 281 milliseconds and to 349 milliseconds in this example in C of a severe prolongation of relaxation. Simultaneously, you would expect the peak E wave velocity to decrease as in C here, because the early diastolic transmedial gradient decreases secondary to the slowing of relaxation. But this is not always the case. Note that the peak E wave velocity in B here remains substantially normal at 70 centimeters per second. And this is because the E wave has several determinants beyond relaxation, including, for example, stroke volume, which includes a significant mitral regurgitation, like a moderate mitral regurgitation, or peak E wave may be increased because there is also a mild, for example, increase in left atrial pressure, which increases the early diastolic atrioventricular gradient and thus the E wave. So it is important to remember that the single indices, the E wave, the A wave, the deceleration time, may be unreliable when taken by themselves because of the interplay of different underlying hemodynamic factors that can influence the profile and the single measurements. So concerning left ventricular relaxation, the E wave deceleration time, the deceleration time here and here, is more reliable than the absolute peak E wave velocity to estimate prolonged relaxation. But currently, the most reliable index at our disposal to estimate relaxation in echocardiography is the peak early diastolic E prime velocity. That's here, here, and here, which compared to a normal value here in panel A, decreases with mild and severe prolongation of relaxation. You can see here a very low value of 3 compared to a normal value of almost 10 in normal physiology. The patient with a mild prolongation of LV relaxation in B has a mean value of E prime of 6 with an E on E prime ratio of 11, which is still normal. But the patient in C with this prolonged relaxation pattern has an E prime, as I said, a mean E prime of 3.3, and the EE prime ratio here is 24, which would indicate already an increased filling pressures, even if the EA ratio is still normal. So please note here, as I have just said, that we are estimating in patient in panel C both a prolonged relaxation, which is based on the EA ratio, the deceleration time, which is increased, and the very low value of E prime, but and which corresponds to a prolonged relaxation mitral pattern, which we will see shortly corresponds to a grade 1 diastolic dysfunction. But we are also diagnosing, because of the increased E on E prime of 24, increased filling pressures. So the increased filling pressures here are in apparent contrast with grade 1 diastolic dysfunction, which by the recommendation should correspond to a normal LV filling pressures. We will get back to this shortly, but this situation does occur clinically when we have a very severe reduction of relaxation, that is to say, a very small E prime. Here are the normal cutoff values for tissue Doppler E prime in the presently in the recommendations. As you can see, peak E prime is age dependent. Here we have 3 categories of patients: 20 to 39 years, 40 to 65, and over 65. Because myocardial relaxation is physiologically dependent on age, it declines with age, so that in older patients there is a physiological prolongation of relaxation, which we don't consider pathologic in our reports. So you can see here that, for example, lateral E prime in a younger, less than 40-year-old patient, the cutoff is 10 because it should be higher than 10. But in a mid-age patient, the cutoff is lower, 8. And we consider a lateral E prime as abnormal in a more than 65-year-old patient only if it's less than 7. So between 7 and 10, here it will be normal. But between 7 and 10 would be abnormal in a younger patient. And so for the average. Another 2 examples for analysis of left ventricular relaxation. Here are 2 patients with aortic stenosis in the upper panel and dilated cardiomyopathy in the lower panel. This is tissue Doppler of the mitral annulus, septal here on left and lateral on the right. The patient with aortic stenosis has a normal ejection fraction and has hypertrophy. The patient with dilated cardiomyopathy has a moderate reduction in ejection fraction and mildly increased filling pressures. We expect prolonged relaxation in both clinical settings. In the 60-year-old patient with aortic stenosis, Up here, the septal E prime is markedly reduced. It's less than 4, whereas the lateral E prime here is normal, almost 12, such that the average is around 7 at the lower limits of normal or mildly reduced. This is explained by the fact that only the interventricular septum in this patient with aortic stenosis is hypertrophied with a marked prolongation of relaxation, which reflects locally abnormal relaxation, whereas laterally the E prime is almost normal because there is no hypertrophy. This is why we should always calculate the mean of the septal or lateral. We must also take and consider that we in fact routinely never analyze the E prime of the anterior and inferior walls, which is a limitation, a big limitations of this methodology of the tissue Doppler, which should be done on 4 points, but it's not because of time limitations. In contrast, the patient with dilated cardiomyopathy here in the lower panels has a severe reduced both septal, you see 4 here, and lateral 6. So the mean E prime is 5, and so this is a moderate reduction of global LV relaxation. The evaluation, the measurement of left ventricular compliance is more complex than the evaluation of left ventricular relaxation. In the majority of patients, but not all, we observe the typical flow, mitral flow profiles that I show you here in panel A and in panel C. The typical profile in the majority of patients, which is named the restrictive filling pattern, as we will see afterwards when we will discuss the diastolic grades of dysfunction, this pattern is characterized by the association of an increased peak E wave, a reduction of deceleration time, so short duration of the E wave, and a reduction of the peak A wave. Okay, these alterations are secondary to an increased left atrial pressure in early diastole, which the gradient increases the flow and the peak E wave, a steeper increase in pressure during early filling, which shortens the deceleration time, so there is a faster deceleration of flow. And we also have a higher left ventricular and diastolic pressure, which decreases the A wave, because A wave is the product of atrial contraction, and the afterload of atrial contraction is left ventricular and diastolic pressure, which is increased and so reduces atrial systolic function. We also have, for the same reason in end diastole, reduction of the duration of the anterograde mitral A wave and a prolongation of the retrograde A wave on pulmonary vein flow, on the pulmonary vein flow pattern. And the pulmonary venous diastolic wave here, D, is also prevalent over the systolic wave. This diastolic wave of pulmonary venous flow is simultaneous with the E wave. The low S wave of pulmonary venous flow reflects a reduced compliance of the left atrium in this situation, which there is dilated left atrium with reduced compliance and increased atrial pressure. We also notice a reduction of the total velocity time integral of the EA wave. There is a reduction of VTI and a shortening of the IVRT, which is not frequently measured, but if you want to measure it, you have to put your pulse Doppler sample volume midway between at the left ventricular outflow and left ventricular inflow. And then you can measure the time interval between the end of outflow and the beginning of mitral inflow. Okay, so these are all the indices that we have to consider, never only one, preferably all together. So the increased PK wave, reduced deceleration time, in reduced or not increased peak A wave, the differences of the duration of the two A waves, the pulmonary venous flow, which is diastolic dominant, the reduced VTIs, and then of course we have an increased pulmonary diastolic pressure. Some indices are always abnormal, like the A wave, the IVRT, the pulmonary venous DU, but some are not always abnormal as expected. For example, the E wave is not always increased, and also the deceleration time may not be always decreased. This is the end of video number 3. Please proceed to video number 4, the topic of which is the echocardiographic grading of diastolic dysfunction.